Welcome to Clinical Minute. Catalina is a 26-year-old woman, gravida 0, para 0, who presents to your office for her annual well-woman visit. She has had irregular, infrequent menses since menarche, with about 4 cycles per year, but just started menses 2 days ago. She is engaged to be married, and while she used condoms in the past with her partner, she has used no contraception since becoming engaged 6 months ago. Catalina has no significant past medical history and takes no medications. She has a sedentary job as a receptionist in a dental office and reports that she does not get regular exercise. When asked, she reports that she tweezes and shaves daily to remove excess facial and neck hair. You ask Catalina about her future plans. One key question is an initiative launched by the Oregon Foundation for Reproductive Health. The initiative encourages primary care providers to routinely ask women of reproductive age a simple question: would you like to become pregnant in the next year? You ask Catalina the one key question. She responds, "No, not anytime soon. My fiancé is in grad school, and we want to get married first, but I figured I couldn't get pregnant anyway, so I haven't bothered with birth control." You use open-ended questions to better understand what concerns Catalina has and what she already knows about her contraceptive options. You then proceed with an exam. During the physical exam, you find the following. Her blood pressure is 130/82. Her body mass index is 28. You recall that a BMI of 25 to 30 is designated as overweight. Her waist circumference, which you measure to determine body fat distribution, is 37 inches. You remember that a value greater than 35 is abnormal. The pelvic exam and the remainder of the physical exam are normal, with the exception of hirsutism. A depression screen is negative. How will you determine whether Catalina has polycystic ovarian syndrome, or PCOS, and how will you counsel her about her family planning options? PCOS is the most common endocrine disorder affecting women during the reproductive years. The prevalence of PCOS is estimated to be approximately 5 to 14% of reproductive-aged women. The National Institutes of Health estimates that approximately 5 million women of reproductive age are affected by PCOS in the United States. The features of PCOS include hyperandrogenism, chronic anovulation, and multiple cysts within the ovaries. However, polycystic ovaries do not need to be present to make a diagnosis of PCOS, and conversely, cysts alone do not establish a diagnosis of PCOS. The exact cause of PCOS is unknown, but experts believe lifestyle and a genetic component play a role. Many women with PCOS display insulin resistance or have metabolic syndrome, although this is not an element of the diagnostic criteria. This feature overlaps with type 2 diabetes. This figure shows the possible complications of PCOS by age of onset. These complications include hirsutism, also in some cases male pattern baldness. Note that hirsutism is strongly correlated with PCOS. Acne, oligoanovulation, obesity, depression and anxiety, infertility, diabetes, including gestational diabetes, and cardiovascular disease. The underlying hormone abnormalities seen in PCOS affect the menstrual cycle and fertility. Chronic anovulation manifests as oligomenorrhea, defined as infrequent menstruation with a cycle length more than 35 days, and secondary amenorrhea, defined as the absence of menstruation for 6 months or more in a woman who previously menstruated. PCOS can result in reduced fertility and dysfunctional uterine bleeding. Women with PCOS are at greater risk for ovarian hyperstimulation and multifetal pregnancy if they undergo assisted fertility treatment. Also, because of chronic anovulation, women with PCOS are at greater risk for endometrial hyperplasia and carcinoma. PCOS management related to menstrual cycle regulation and fertility differs based on whether the woman is currently attempting to conceive or not. For all women with PCOS, lifestyle modification, with weight reduction of 5 to 10% if overweight or obese, will help improve menstrual cycle regulation and fertility. It is important to discuss contraception with all patients who are not currently attempting to conceive, because treatment of PCOS is likely to increase fertility. Other things to consider include: combined oral contraceptives are first-line treatment. They suppress androgen secretion and increase circulating sex hormone-binding globulin, which reduces free testosterone levels. Progestin-containing contraceptives have a smaller anti-androgen effect. If a progestin-containing contraceptive alone is ineffective, another option is to add anti-androgen such as spironolactone or cyproterone acetate. Metformin is associated with reduction in circulating androgens, increase in ovulation rates, and improved glucose tolerance, but is recommended only for women with PCOS who have glucose intolerance or type 2 diabetes. Several contraception considerations that are specific to women with PCOS include the timing of desire to conceive, the choice of contraceptive, and effects of obesity. The timing of the desire to conceive is important for women with PCOS because of the need to minimize the health risks associated with PCOS before conception. Care providers should discuss the importance of timing conception and contraception with patients who have PCOS. It's also important to consider comorbidities, such as hypertension, and risk factors, such as smoking, when considering specific contraceptive options. Care providers should refer to the CDC's U.S. medical eligibility criteria for specific recommendations. Generally, the choice of contraceptive should reflect the goal of reducing circulating androgens. The third consideration is the effect of obesity on contraceptives. Obese women engage in sexual activity as frequently as all other weight categories. Although obese women have decreased fertility, most ovulate regularly and are thus at risk for unintended pregnancy. Research suggests that body weight has no impact on the effectiveness of the contraceptive implant. Studies on the effectiveness of combined hormonal contraceptives in obese women are conflicting. However, it appears that women with obesity have a similar or slightly higher risk of pregnancy on combined hormonal contraceptives than women who are not obese. It is important to keep in mind that contraception will always prevent more pregnancies than no contraception. According to ACOG Obesity Project, the levonorgestrel-releasing IUD is associated with a small weight increase. DEPO MEDROXYPROGESTERONE acetate is associated with weight gain more often than loss, especially in obese teens. And other contraceptives showed no association with weight gain. Because Catalina has clinical signs of hyperandrogenism, specifically hirsutism, a serum testosterone is unnecessary. Note that hyperandrogenism needs either clinical or biochemical verification, unless there is a concern about virilization from other causes. If labs return normal, thus excluding another diagnosis, the presence of an ovulation, as indicated by the oligomenorrhea, and hyperandrogenism meet the criteria for a diagnosis of PCOS. Catalina schedules an appointment to return in 1 week to review results and devise a treatment plan. 1 week later, you review the lab results with Catalina, which include 2-hour oral GTT, fasting, and 2-hour impaired range. Serum lipid profile, mildly elevated LDL. Free testosterone, moderately elevated. TSH, prolactin, 17-HP to rule out other causes of hyperandrogenism, normal. What do you say when counseling Catalina? Based on the lab results, you tell Catalina of the diagnosis of PCOS and the presence of some cardiovascular risk factors. You ask open-ended questions to better understand Catalina's preferences for contraception. You suggest a combined hormonal contraceptive with low androgenic activity, a hormonal implant, or a vaginal ring to regulate her cycle, for contraception, and for hirsutism. She decides on the hormonal implant because she doesn't think she would remember to take a pill every day. You also recommend steps to reduce weight with increased activity and a nutritionist referral. You let her know that when patients with PCOS lose weight, they sometimes become more fertile, thus increasing the importance of contraception. You know that according to the CDC's selected practice recommendations for contraceptive use, the implant does not require blood pressure checks as are required with combined oral contraceptives because it is a progestin-only method. You ask her to follow up in 3 to 4 months so that you can check on her satisfaction with the chosen method and her progress with weight reduction.